Bismillahirrahmanirrahim. This is a discussion of another two cases of ABG discussion or interpretations. I just remind you that before we start reading the chart of the ABG, you have to take care that you have to take a history, clinical status of the patient, which makes easy for you to define what is the underlying pathophysiology or pathology. And in addition to these, you have to look at the lab investigations and the radiological investigations, which will give you also a hint of the anticipated problems. Then look at the ABG chart, and after that fill the monographs, and then calculate the monitors is corrected by cabinet to be calculated, collide sodium ratio, anion gap, corrected anion gap, strong ion differences, buffer base, strong ion gap, base excess, alveolar oxygens, and alveolar arterial gradient. Let's go to this case. This is a patient, is a critically ill patient with septic shock. So this septic shock gives you a problem. This patient is having most probably the problem of high anion gap metabolic acidosis and multiple organ failure also. The management has consisted of cardiopressor, mechanical ventilations, and this mechanical ventilation will make some sort of errors in the carbon dioxide. This will not be physiology. Antibiotic and a large volume of normal saline. So normal saline, hyperchromic metabolic acidosis. This is the picture from the history itself. Yeah, this is the data of the patients, and let us look at the data in the monograph. This is a patient who is pH is 7.1, severely metabolic acidosis. Metabolic because the bicarbonate is low, and from the history we said that the patient is septic shock, metabolic acidosis, took a large volume of normal lines. This is also hyperchromic metabolic acidosis. This is what give you us or give you some good clue for the anticipated pathology. When you look at it, this is bicarbonate. Bicarbonate is 9 instead of being 24. This is difference is 15. 15 each one loss of bicarbonate with loss of 1.2. When you multiply 1.2 by 15, gives you about 18. And 18. This is 18. This is the carbon dioxide, expected carbon dioxide 40 minus 18 will give you 22. But here it's 30 because the patient is on ventilator. So this is a failure of adjustment. This means that the patient is hypoventilated. You should make some sort of wash out of carbon dioxide instead of being 30 to be 22. When you give 22, something like that, this is gives you another important problem. So from this part, this is a patient is metabolic acidosis, but the conversation is not complete. So this is needs some sort of ventilatory adjustment. When it comes to the sodium is 130, which is low, potassium is low, chloride is high, 111. When you look at the chloride sodium ratio is 85. So this means that the patient is having a high load of chloride. That's why the patient received a large volume of saline. And this large volume of saline resulted in the formations of hyperchloremia. So this hyperchloremia, when you look at the anion gap of this patient, anion gap of this patient is 130 minus 111 plus this bicarbonate gives you 10, which is less than the normal. But this is less than the normal. It is anion gap, low anion gap. What is it? Low anion gap. Look at the albumin. Albumin, the patient is having hypoalbuminemia. Hypoalbuminemia, this means that the patient's, the original state of the patient with hypoalbuminemia should have high bicarbonate. So this is, if you say that this is albumin is 1.5, instead of being 3.5, this means that there is a drop of 2. And each one decrease in the albumin will be associated with the increase in the bicarbonate by 2.5. So this is the bicarbonate should be more by 5. So this means that the bicarbonate, the original anion gap of this patient, instead of being 12, should be 7. So this is be a high anion gap. And in addition to this, come to say what is the corrected anion gap. Corrected anion gap, this is anion gap plus the difference. Here this is albumin 3.5 minus 1.5 multiplied by 2.5 gives you the 6, and this is the corrected anion gap 16. So this is if you take it from this point that this patient is having a high anion gap. This is a high anion gap. This is 16 and instead of being 12, or this is 10 and instead of being 7. So this is high anion gap metabolic acidosis. So this is high anion gap metabolic acidosis. This is due to lactic acidosis. But in addition to this, when you look at the chloride is high, this is leads to a hyperchloremic metabolic acidosis. Look at the strong ion differences. Another point. Strong ion differences. This is the difference between sodium and chloride. It is less than 40. This is metabolic acidosis with normal anion gap metabolic acidosis. This is a normal anion gap metabolic acidosis, which is hyperchloremia. So this is another problem. So the patient is having normal anion gap metabolic acidosis, and at the same time he is having high anion gap metabolic acidosis. And when you look at this is carbon dioxide is not completely washed out. This is respiratory acidosis. And when you look at the ABG, this patient was on ventilator, mechanical ventilations, with FiO2 40. Alveolar oxygen gradient was very high. That's why the patient was hypoxic. The patient hypoxic with a stiff lung, and therefore the washout of carbon dioxide was not complete. So they developed respiratory acidosis, and the patient is hypoxic in addition to the septic shock. He had high anion metabolic acidosis, and the use of a lot of sodium of sodium chloride or saline resulted into a normal anion metabolic acidosis. So it is a mix of normal anion metabolic acidosis, high anion metabolic acidosis, and in addition to this respiratory acidosis. This is the state of this patient. Come to this is the last one, which is this case a patient aged 52 years old, and he developed sudden loss of consciousness. The cause is not written here, and the respiratory distress, both on mechanical ventilations. And after 3 days later, the lab investigations were taken. And these are the lab investigations. You look at this. This is the most important one of this is the album is low. Look at this patient. He's on mechanical ventilations and developed some sort of respiratory distress. So the pH here is a little bit 7.43. It is alkalotic. Carbon dioxide is 24 and bicarbonate is 17. So this is 17 bicarbonate. This is metabolic acidosis. And this metabolic acidosis should be associated with low wash out of carbon dioxide, about 8 millimeter mercury. But here, since the patient was on ventilator, the carbon dioxide is more washed out. Instead of being 32, it is 24. So a ventilatory adjustment here, this wash out of carbon dioxide. That's why the problem here is a little bit metabolic alkalosis. So the metabolic alkalosis, although this is a ventilatory drawback. And the ventilator is not adjusted. You should adjust the ventilator in order to keep the partial ratio of carbon dioxide 32 instead of 24. Yeah, come to the study. The sodium is 161. Is it heme concentration or something else, or addition of large volume of sodium of saline? Chloride is very high, 128. What the ratio between the two, chloride to sodium, is 0.79. So this means that there is some sort of heme concentration. In addition to this, there is a high chloride load. So this high chloride load, how can you know? Look at this is strong ion differences. Strong ion differences is 33. This means that this patient is having some sort of metabolic acidosis, hyperchloremic metabolic acidosis. This is a volume. This is due to the saline infusion. He developed hyperchloremic metabolic acidosis. When you come to the bicarbonate, this is 17. What did the previous state of this patient before he developed some sort of respiratory distress or and to be put on the ventilator? Look, this is bicarbonate plus the anion gap plus the minus 12. This will give you this, but here the anion gap here is 16. Look at the protein. The albumin is low. When you have to correct this, anion gap should be corrected, and instead of being 0.24 should be 3.5 or 4. So this is the difference, about 1, and this one gives you about 2.5 milliequivalent for bicarbonate. So the corrected bicarbonate in this case would be 20. So this is a high anion gap metabolic acidosis. So this is high anion gap metabolic acidosis. When you come to the corrected bicarbonate, this is the corrected anion gap minus 12 give you 25. So the patient was normal. He was normal before this sequelae of events. The patient developed a hypoalbuminemia, and this hypoalbuminemia means some sort of change of the original bicarbonate. There's increase in the original bicarbonate, and after that the patients developed some sort of lactic acidosis, and this can be seen by strong ion gap. Strong ion gap is high. This strong ion gap is high. This means that is an acid has been added. In addition to this, strong ion difference is low. This is most due to saline. Normal. This is a normal anion gap metabolic acidosis, and this is a high anion gap metabolic acidosis. This is a high anion gap. This is so the patient has high anion gap metabolic acidosis, maybe lactic acidosis, normal anion gap metabolic acidosis from normal saline infusions, and this high anion gap due to additions of lactic acid most probably. And in addition to these, he needs some sort of adjustment of the ventilator because he is having respiratory alkalosis due to washout of carbon dioxide by the ventilator. When you come to the patient, he is having the oxygen is bad, oxidation index is bad, alveolar oxygen is very high, about close to 200. This is very high, so the patient is hypoxic in addition to the previous state. So the patient from this chart can come to a lot of conclusions. Hypoxic patients with the need with respiratory alkalosis needs to be adjusted. In addition to this, the patient had to high anion metabolic acidosis and a normal anion metabolic acidosis due to hyperkalemia due to sodium infusion. Thank you.